Thank you, sir. Yes, sir. Perfect.
We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 190, Retina Session 42. And today we have with us Dr. V.R. Sarvanan, sir, and he'll be talking on optic disc anomalies, PITS, and associated serous macular detachment. I request Dr. Ritesh Narula, sir, to please introduce Dr. Sarvanan, sir.
Good evening, everyone, and thank you, Dr. Sarvanan, sir, for coming here to teach us such an interesting topic. Dr. Sarvanan, sir, doesn't need any introduction. He's a surgeon par excellence, has been a teacher to a lot of us. We have been listening to his talks on different difficult retinal conditions, retinal surgeries, and it has always been a great pleasure learning from him. Sir is sir has done his MBBS from Madurai Medical College, then DNB from Coimbatore, and he was the first PR fellow from Arvind Eye Hospital, Coimbatore. And sir has multiple papers and publications and has chaired multiple sessions. This particular topic, the optic disc pit, we have seen sir's videos tackling this difficult condition, and we are really looking forward to hearing and learning from you more. Thank you, sir.
Thanks, Ritesh. Shall I start my PPT now?
Yeah, sure.
Yeah. Thanks for the opportunity, Santosh sir and AOS team for giving me this opportunity. Are you able to view my slides now?
Yes.
Full screen?
Yes.
Okay. So this mainly I will be talking about various optic disc anomalies which we see in our routine day-to-day practice. And more commonly, what we see is the complications because of optic nerve pits and the sequelae, which is the serous retinal macular detachment. So when you're examining the fundus in a routine patient in your OPD, you can have a normal disc, you can have a disc which is slightly larger or slightly smaller than the normal population. So when you have a small disc, what are things to keep in your mind is like where there is a little bit small disc with no cup, which we call it as disc at risk, which is more more prone for developing ischemic optic neuropathy. And then we have the so-called tilted disc because of the oblique insertion of the optic nerve into the sclera. And also we have the congenital anomaly, which is optic nerve hypoplasia, where the disc is much more smaller and can be pale either segmentally or overall paler. And also sometimes you have this hypermetropic disc with a little bit of tortuosity of the venules. When in especially in non-ophthalmic patients, you will see much more prominently. So these are something which you have to keep in mind when you're looking at a disc which is slightly smaller than what you would normally see in your clinical practice. So optic nerve hyperplasia is one of the commonest congenital anomaly regarding the disc. What we see that approximately can be the cause of 15 to 20% of vision loss as a congenital cause of vision loss in the child population. And it's a non-progressive disease. And what you see is the typically smaller disc compared to normal population. And if you do a OCT in late stage, you'll be seeing either a total nerve fiber layer thinning, or sometimes it can be limited to segmental areas. And what the clinical classical what are the findings is the so-called peripapillary double ring sign. And also you can have a little bit of tortuosity of the retinal arterioles and venules. And it can be either unilateral or bilateral. So diagnosis is made by apart from the smaller size and the double ring sign. So what you see here is the disc to macula distance, which is usually approximately 2 to 2.5 in a normal population. Here what you see is more than 3 disc areas. If the disc to macular distance is more than 3 disc areas, then you'll have to, that's a pointer towards optic nerve hypoplasia. So when you have optic nerve hyperplasia, you'll have to think about other neurological abnormalities which can be present. So neuroimaging, MRI imaging of all these children is very critical to diagnose the other associated findings. So approximately 60% of this population will have some sort of neurological or endocrine abnormalities. And MRI can depict the presence of hyperplastic optic nerves with a hyperplastic chiasm, other also cerebral abnormalities, which can include gray-white matter hydrocephalus, septo-optic dysplasia, and also corpus callosum abnormalities. So some of the causes which can induce optic nerve hyperplasia is alcohol and drug abuse in the mother, apart from intake of teratogenic agents, maternal diabetes, alteration in the prenatal development during the 6th week and 4th week of 4th month of gestation. So all these can be a cause of optic nerve hypoplasia. So vision loss is usually more related to the integrity of the papillomacular bundle rather than the absolute size of the optic nerve. So doing a OCT scan and analyzing the retinal nerve fiber layer can give an idea of what is the range or severity of involvement of the optic nerve fiber layer, and it will give an idea of why the vision is so poor. Sometimes superior segmental optic nerve hyperplasia with inferior visual field defects has been associated with the presence of maternal insulin-dependent diabetes. And vision tends to remain in the stationary same throughout the life, and there's no risk of late onset vision losses, unlike some of the other conditions which we'll be seeing. And in patients with significant field defects, retinal afferent pupillary defect will be seen, relative afferent pupillary defect will be seen. They're looking at the pupil. So this is what typically we see: small disc with large retinal vasculature, and in extreme cases, an area of vascula can be seen around a small optic disc, like I showed in the first picture. And typical double ring chain, which can be pigmented or non-pigmented, can be seen around the disc. And associated findings, ocular findings, can have microphthalmus, anidria, coloboma, nystagmus, and strabismus. So other cystic, I told you about the neurological and endocrine abnormalities. So other endocrine abnormalities which can be seen is thyroid growth hormone deficiency, adrenal and antidiuretic hormone deficiencies. So this can be more commonly seen in bilateral cases, and especially in patients with midline defects. So hypothalamic and pituitary dysfunction and development delay can also be associated factors with these children. So agenesis of the septum pellucidum, septo-optic dysplasia leading to mental retardation and spasticity, anencephaly, cerebral atrophy, basal encephalocele, hyperplasia of the cerebral vermis, cystic dilatation of the fourth ventricle, all these can be some of the associated findings. So it's very critical to image these babies with the MRI to rule out other intracranial abnormalities, and to look at the endocrine profile, mainly fasting cortisol, glucose, TSH, insulin growth factor, and also prolactin, because in these patients sometimes sexual development delay can also be seen in the later coming years. So luteinizing hormone, FSH, testosterone levels to be tested to anticipate delayed sexual development. Next, more commonly seen disorder is the so-called morning glory disc, or MGD, which is short form of this. It was described by Kindler in 1970, and he named this because the disc looked like a resemblance to the typical morning glory flower, which we commonly seen in our in the botanical gardens. And what you see is the enlarged excavation of the optic nerve, with very abnormal, some sort of radial vascular pattern, which is not routinely seen in our population. So the vessels will be more radially oriented, which is giving that typical morning glory flower resemblance. And you can see annular pigmentation around the disc, and also sometimes you can see the center of the optic disc, the presence of a glial tuft. So this is the typical picture of what I described now. You can see the almost radial orientation of the retinal vessels arising from the center of the optic disc, and also the presence of the typical glial tuft at the center of the optic disc. So it can be unilateral and occurs commonly equally between male and female population. And the embryonic development alteration of the lamina cribrosa and posterior sclera is supposed to be the cause for this developmental anomaly. And there's no specific genetic defect associated with this condition. It's more or less sporadic. And most of these eyes will have a significant vision loss. And only 30% of the people have a better vision in the reported literature. So other associated ocular findings is can see optic nerve calcium apart from the glial tuft, can have a smaller eyeball, and also retinal detachment is very quite common in these eyes. And managing this retinal detachment is quite difficult, because sometimes you see that both PFCL oil can migrate under the subretinal space, and the success rate of these surgeries also is not that very great. Sometimes you can have a pulsatile optic disc in this patient, which corresponds to the CSF pressure, and that can be seen during intraoperative when you're doing a surgery. So facial abnormalities associated with the morning glory disc is hypertelorism, cleft lip, and cleft palate. CNS abnormalities can include encephalocele, corpus callosum agenesis, and it's been associated with this morning glory disc has also been shown to be associated with Moyama disease, which is what we see in abnormal narrowing of the cerebral arteries. What you see in Moyama disease. So this has been described with the MGD deformity. And also the associated endocrine abnormalities can also be seen in these children. So management as such is if RD occurs, we'll have to do RD surgery, and not a very successful outcome can be seen in a lot of patients. And apart from that, and in the presence of refractive errors, amblyopathy therapy will be critical to sort of bring up the vision in these patients. And also you have to rule out other CNS abnormalities by doing a neuroimaging in these children. The next small disc, what you other cause of small disc is the tilted disc and congenital tilted disc syndrome. So what you see here is the optic nerve appears to enter at an oblique angle rather than the perpendicular angle which is seen in normal population. So you have a sort of a tilted configuration of disc, and also the vascular architecture also seems to be directed in an oblique pattern. The supratemporal part of the eye is more elevated, and the infranasal part of the globe is more depressed. So supratemporal is more closer towards the cornea, and the infratemporal is more away from. So it's a sort of have a abnormally shaped posterior globe of the posterior codes, and half of the cases can be bilateral. So the cause, one of the causes has been the malclosure of the optic embryonic optic fissure, and refractive error is quite common. Some people can have color vision alterations and also field defects. So because of this abnormal shaped posterior sclera, there's what you can have is like a CSR like maculopathy can happen in these patients. What we call as dome shaped maculopathies can happen high risk in these patients. Apart from this, at the edge of the so-called dome, you can have a chorioretinal thinning, posterior staphyloma because of the posterior staphyloma. At the edge of the highest point of the sclera, you can have a chorioretinal thinning. You can get peripapillary atrophy. Sometimes you can get CNVM also in this patient, and also higher risk of glaucoma in these eyes. So when you have a large disc, some of the things which you have to think about is apart from optic disc coloboma, we'll have to think about the presence of optic disc pit. You can think about I already talked about morning glory syndrome, and it can be all these deformities can sort of mimic glaucoma. So when you have this abnormal shaped cupping in these large discs, you'll have to rule, even though it may mimic glaucoma, so you must make sure that it is not one of these anomalies and glaucoma only before you start treating. Sometimes people have wrongly been treated as a glaucoma is optic atrophy in patients with large disc and optic nerve coloboma. So you'll have to sort of differentiate between these conditions when you're diagnosing glaucoma in these cases, especially the size of disc is abnormally larger. So optic disc coloboma can occur as an isolated deformity only involving only the optic disc, or it can involve the infranasal part of the retina, uvea, and sclera. So what we call as a retinochoroidal coloboma, or it can involve only the disc as a sharply demarcated white excavation that replaces the inferior part of the optic disc. And it doesn't have any special genetic predisposition. It's more or less sporadic, and vision corresponds to the level of the involvement of the papillomacular bundle. And whether the other retinochoroidal coloboma is involved in the macula also will define the presence, how good the vision is in these patients. So other associated ocular findings include microphthalmos, iris coloboma, ciliary coloboma, lens notching, retinal detachment, and neovascular membranes can also occur in these patients. Especially in the presence of a retinochoroidal coloboma, diagnosing the CNVMs is quite difficult because there's considerable pigmentation and scarring at the level of the edge of the retinochoroidal coloboma, and identifying these minuscule CNVMs can be a little bit difficult. So doing a fluorescein and OCT and looking at the cuts very carefully will only be able to diagnose this small neovascular membranes which occur in the presence of retinochoroidal colobomas. Macular holes and also retinal detachment is more common in presence of retinochoroidal coloboma. In isolated optic nerve coloboma, you don't get a REG-RD, but what you can get is a serous effusion, which can have a waxing and waning course, like a CSR. It can come and go. So this can sometimes be seen in patients with optic disc coloboma. So genetic associations include renal coloboma syndrome, which can have the PAX2 mutation, and the charge association where you have a coloboma, heart defect, corneal atresia, retarded growth, and gentle hyperplasia along with ear abnormalities. So this can be a cause of the optic nerve coloboma. And also Aicardi syndrome, which will be showing a picture of in the last slide. And Goldenhar can also have associated with this syndrome. So the association of optic nerve coloboma with distension of the internal carotid artery and transplanar encephalocele with hypopituitarism has led to the suggestion that the link can be between the eye malformations and the neural crest cell development. So this is one of the theories how this develops. That's what they say. So when you have a optic disc coloboma, you'll have to differentiate this from the so-called posterior ONH excavation, which is more of a staphylomatous deformity surrounding a normal optic nerve. If you look at the left picture, you have an enlarged disc with a large cup-like appearance, mimicking a large glaucomatous optic atrophy, which is a ONH coloboma. And the right picture, what you see is a normal optic disc, which is placed within an excavated posterior sclera. So it's called a ONH excavation or a posterior staphyloma in the optic nerve. So this is otherwise also called a peripapillary staphyloma. So this can be non-hereditary, usually unilateral, and deep excavation is seen as a deep excavation of the sclera around the optic disc. And optic disc itself is normal with a normal vasculature, unlike what you see in a morning glory syndrome. So morning glory syndrome, the whole disc margin and architecture is totally altered with the radial orientation of the blood vessels. But what you see here is almost a normal disc with a normal vascular pattern, which is located within the staphylomatous area of the posterior pole. And usually vision is quite decreased in these patients, which can be associated with myopia. It can also be seen in hemotrophic eyes also. So in myopic patients, you'll have to ensue amblyopia therapy. And associated CNS abnormalities include frontal nasal dysplasia and basal encephalocele. So the next is the what you call as the megalopapilla, which is almost looking at normal disc with only the size is a little bit larger. So here what you see is an enlarged optic disc with a normal disc morphology, and it can be bilateral, which is the offset is more than 2.1 millimeters. Also can be unilateral with a large excavation which albeit the adjacent neuroretinal rim. And when you do a fluorescein, HFA, what you will see is seeing a large blind spot, and people may or may not have vision loss. Mostly it is mistaken for a glaucomatous optic atrophy. So then what you come to one of the commonest seen diseases in adulthood, which mimic is whenever you have a central serous retinopathy like diagnosis in your exams, always make sure that you look at the disc margin, to rule out any optic disc pit, because treatment for optic disc pit and a CSCR is totally different. So optic disc pit is a sort of a rare congenital anomaly of the optic disc, which can be complicated by a maculopathy, which is associated with progressive vision loss in a small percentage of the population. And these are usually bilateral and sporadic in occurrence. And maculopathy itself is not can be triggered by unknown, no known triggers are there. It can again. It can have a waxing and waning course. It usually mimics central serous chorioretinopathy. So whenever a CSR like macular fluid is seen, always look at the disc to rule out the presence of a pit. So as I told you, 90% of this population is unilateral, and dysplastic retina herniates into a pocket-like defect in the lamina progressa, and it's seen as a dark area, usually on the temporal half of the disc, near the margin of the disc. Sometimes it can be central also, and the size is usually 1/4 or 1/8 of a disc area, and large temporal pits are more commonly associated with the serous detachments. So if you do a fluorescein, you'll be seeing a non-perfused area and like a dark spot in the disc, which corresponds to the pit. And if you do a OCT, you'll be seeing like a bottomless pit-like appearance in that area. So usually it's asymptomatic unless there is a macular detachment, and otherwise it is totally patients will not realize that they're having these complications. So doing a OCT, a field effect, FAF, and also FFA can rule out this disease. Again, the presence of large pits can mimic glaucomatous optic atrophy. You should be aware that this is one of the DDs for a glaucomatous optic disc. So I just show some OCT picture, and this maculopathy has been reported to occur between 20% to 70% of these populations, and usually it happens in the 2nd to 4th decades of life. And where is the source of this so-called submacular fluid is again a little bit contentious. So more commonly, people feel it is the syncytic vitreous fluid which tracks from the vitreous space into the pit, and from there into the subretinal or intraretinal or sub-ILM space. So one of the other theories is that that cerebrospinal fluid from these perineal subarachnoid space can track. Because one of the cases a report has been that after putting oil fluid has been PFCL has been demonstrated in the optic nerve sheath in the MRI post surgery. So exudation. One other next theory is that exudation from the blood vessels at the base of the optic disc pit can give rise to this submacular fluid. And other last theory is that the fluid comes from exudation from the exudes from the choroid through the Bruch's membrane, and that causes this so-called peripapillary atrophic area tracks into the retina. but mostly accepted is the vitreous origin, where the fluid from the vitreous cavity, synthetic cavity, enters into the interretinal and subretinal spaces, sometimes into the subialum space also. This is a OCT showing the presence of a pit and a large CSR-like submacular fluid. You can see that the fluid is not only in the subretinal space, but can be seen in the intraretinal space also, like a sky, what you call as a macular schisis. And you can see the very thin foveal area. Sometimes this can break into a macular hole, especially when you're doing ILM peeling these eyes. This is one of the risk factors. So what are the treatments when you have a submacular fluid or a CR like SRF in the macula? So what has been tried is, one of the commonest is the laser treatment, where you put a row of laser at the temporal margin of the disc, usually 1 to 2 rows, in the just temporal to the optic disc. So this is, but again, this has not been shown to be that very successful in isolation. So laser treatment, even though that was the commonest laser treatment and some time back, now it is less and less performed. But you can, as a initial therapy, you can try this for serous elevations of the macula associated with ONH pit. So next has been a treatment that has been tried is gas injection into the vitreous cavity. And prone positioning, where the gas sort of goes in and obstructs the optic nerve pit, preventing vitreous fluid entering into the submacular space. So this has also been tried, plain pneumatic displacement with the closure of the optic nerve pit. And there has been limited success experience with this technique. And then some of the surgeons also have tried a macular buckling, where you put a sort of either a T-buckle or other dental implants which are hooked onto a sponge. And limited, again, it's not that very commonly performed surgery. It's but one of the tried techniques for SRF associated with the ONH pits. But what we most commonly do is vitrectomy. So plain vitrectomy with gas also has been attempted in these eyes. But again, the success rate is not that very great. So then people started trying to close these holes with the various tissues or various materials. So the most common thing was ILM. Then we have the some people have tried the scleral graft, and all the other some people have tried even blood, autologous blood or serum. Thrombin has been tried. So many things have been tried. So other techniques is where people have tried to drain the SRF through retinotomy. That also has been tried, but again with limited success. So this is one of our older cases where we are doing a serous maculopathy. So in the initial days, we used to do just a routine ILM peeling and put in gas without attempting to do any other steps. But again, the success rate was a little bit limited, so not very great. Then we started combining laser with ILM peeling, which was added a little bit of more success. Then now recently we are trying to stuff the various tissues into the optic nerve pit to increase the success rate. So this is one of the studies which showed that considerable success with the plain ILM peeling. But because the foveal area can be quite thin, doing a plain ILM peeling can sometimes end up with a complication called iatrogenic macular hole, which can happen because of this force of stripping the ILM from the this is one of our eyes where we did a plain ILM peeling. You can see that post-operatively, the macula has developed a secondary or iatrogenic macular hole, which can be an issue. So now people tend to do what we call it as fovea sparing ILM peeling to prevent this side effect. So Spade et al. Showed a limited success with what they call as inner retinal fenestration with a sharp a needle made multiple half thickness penetration in the papillomacular bundle area. His assumption was that the fluid which is
So can you hear me? One second.
Rolika, has Dr. Sarvanan's?
Yeah, I think so. He got disconnected. So 1 second. I will just cross-check with him.
Sorry to all the listeners. Technical glitches do happen. Just give us a couple of minutes to sort it out.
Probably, so he'll be reconnecting in a moment, so.
Right. Thank you, Ravi.
Yeah. So it's
Yes, sir.
yeah.
Welcome
Sorry,
back.
it got.
No
Sorry.
problem, sir. No problem, sir. Carry on, sir.
Okay. Sorry.
Saravanan sir, we were at the phobia sparing
Yeah.
discussion.
Sorry. I'll just start.
Yeah.
Yes, sir. There.
Yeah.
So probably
this is a
one
very-
slide before that, sir.
Yeah, so this is now the currently preferred technique is trying to close this sort of optic nerve pit with various sealants, which can be autologous platelets, fibrin sealant, autologous scleral flap, and also the inverted flap from the using the ILM, so patient's own ILM. So now we do what we call as phobia sparing ILM. So here you can see the induction of the posterior vitreous detachment in a young kid around 8 years old, with the optic nerve pit and a large submacular fluid. So once the PVD is induced, we stain the ILM by injecting brilliant blue-green, brilliant blue G, sorry, and then brilliant blue dye. And then once the ILM is stained, so this is what we call as a phobia sparing ILM peel. So here we try to avoid involving the fovea, because the thin fovea can sometimes rip into a secondary macular heterogenic macular hole, causing vision loss in these patients. So you can see starting the ILM peel nasal to the fovea here, and then this ILM is sort of stripped and reflected back onto the optic nerve pit. And then this is finally pushed into the disc pit, so to sort of occlude the physically close this ONH pit and prevent the migration of sciatic vitreous fluid into the subretinal space through the optic nerve gap in the optic nerve through the pit. So once we do this sort of strip the ILM and push it into the optic nerve pit, and under air, this is sort of pushed into the optic nerve pit, providing a physical barrier for the migration of abnormal fluid, vitreous fluid into the submacular space. So recently, what we have been doing, and the most successful amongst the surgeries performed, is the autologous scleral graft. Here, a small tissue scleral graft is manufactured from the patient's own sclera. And after doing PVD, vitrectomy and PVD induction, ILM peeling, some people do, some people don't do ILM peeling. And this scleral graft is pushed onto the optic nerve pit to sort of fill the gap and provide a physical barrier. And depending on the patient's compliance, in adult patients usually inject gas, and in very small kids sometimes we inject oil, because patients will do not push in properly in the immediate postoperative period. But again, this is one of the commonly performed techniques today with the most success rate. So autologous scleral graft is currently the surgery for choice in patients with maculopathy secondary to ONH pit. And this is showing the response in some of our patients. You can see the graft sitting over the optic disc with the resolution of the submacular fluid. One more case showing the graft filling the pit, and almost the SRF is a little bit there, but still it's almost resolved, and it's on the process of resolution. So advantage of this, as I told you, amongst all the surgeries, is the scleral graft is much more heavier and much more thicker and easier to sort of mobilize and place inside the optic nerve compared to the ILM and other sealants. So this is one of the commonly and the most successful surgeries performed in current scenario. So I wanted to show one more case where, as I told you, this fluid which migrates into the optic nerve pit can go into the submacular space, can go into the intraretinal space, but also can sometimes enter the sub-ILM space. This is one more kid who came to us with the ring scotoma, complaints of ring scotoma for the past one month. And you can see that the fovea is normal, but you can see a sort of an annular TRD surrounding the fovea. You can see that the ring like TRD. So this is FFA showing the dark area of, at the temporal margin of the optic disc, and there's no leakage as such from any of the structures. And this is the OCT showing the annular TRD or a circular TRD. So as normally the ILM does not peel freely beyond a limit, and the ONH pit was leaking fluid into the sub-hilum space, and because of the hilum was not separating beyond a point, you can see the hilum is sort of pulling the surrounding retina, causing a traction retinal detachment, which is an unusual complication of ONH pit. So fluid can not only go into the retina, under the retina, but it can also go above the retina, within the hilum, between the hilum and the retina. So here what we did was do a surgery to sort of, is a very more simpler surgery, just to cut the hilum and allow the subhilum fluid to come into the vitreous cavity. So again, there's injection of PVD, and you can see that here the PVD is induced. So sorry. So trying to peel the hilum all around, open that hilum cavity so that all the subhilum fluid can enter the vitreous cavity. And you can see the resolution of fluid now. You can see some pigments because of the surgery, but the fluid has all gone down into the inferior retina, and the vision now you can see is improving now. Vision was always 6/6, only she had a sort of a perifoveal, paracentral scotoma, ring scotoma. So again, I showed you, there's a picture showing that the fluid can go into any space, intraretinal, subretinal, and subhilum. So one more associated with similar submacular fluid is idiopathic macular schisis in normal tension or a low tension glaucoma, where the sort of this gaps in the lamina cribrosa can act like optic nerve pits. So this is actually a old showing example of a case of which can mimic ONH pit associated maculopathy. So old patient who had already had a polypoidal choroidal vasculopathy in one of the eyes, and this is the PCV showing the cluster of grapes appearance in the ICG. So we did a PDT for this patient for the left eye, but he was slowly losing vision in his right eye, and the IOP is only 17. But the cupping was slowly increasing during the course of treatment from 0.4 to 0.65. And the HFA also showed a superior arcuate scotoma. So he started on anti-glaucoma medication. This is a HFA showing the presence of field defect. And you can see the change in cupping from 2006 to 2010, enlargement of the cup as the years progressed. And so here, because he was losing vision, you can see a slight alteration in the macular, just in the below the fovea, in the papillomacular bundle area, just below the fovea. You can see the striations are a little bit more prominent in these areas. This is the area where the abnormality was seen. FAB did not show any leakage, both in the, even though we were suspecting PCV, which was present in the left eye, for which he had already undergone treatment, but there was no signs of any PCV in this eye. This is the evolution of schisis. In 2009, it was very limited and was slowly extending. And by 2011, it had started involving the fovea of the associated vision drop. So you can see a similar sort of a large cup in the OCT with the presence of intraretinal fluid, which you typically see in a ONH pit. But we were searching and could not identify ONH pit, and where various DDs were proposed. But finally, we came to diagnose idiopathic macular schisis in a glaucoma. And this is because of the presence of this micro holes in the lamina cribrosa, which can act like ONH pits, especially when there's a large diurnal fluctuation in IOP. This can lead to all these sort of macular complications. So people have done surgery, both trabeculectomy also has been shown to be able to treat this eye because the fluctuations are avoided, and that leads to resolution of these cases. And people have tried vitrectomy also to try peeling that sort of glial tissue which is there in the optic nerve cup area, and that has led to resolution of the fluid in the submacular space. In our eye, because the patient was quite old and not willing for surgery, we did just a laser for as I told you in the as a treatment for ONH pit. Similarly, we did 2 rows of laser on the temporal margin of the optic disc, and that led to the resolution of this fluid in our case. You can see this is the post laser, immediate post laser, and finally you can see after around 1 or 2 years on follow-up, you can see the almost normalization of the fovea, even though there's still some minimal schisis present, but it has considerably decreased from the initial time. You can see the comparative pre and post laser in this patient. Within 4 to 6 months, the intraretinal schitic fluid came down considerably. So other associated anomalies of the optic disc include myelinated nerve fibers. So normally the myelination of the visual pathway starts at 5 months of gestation and ends at the lamina cribrosa at birth. But sometimes anomalous migration of the oligodendrocyte glial cells can happen before the lamina cribrosa forms. and this can lead to the presence of white flame-shaped lesions, and associated ocular findings can be myopia, amblyopia, and field defects, apart from vision loss due to secondary optic atrophy. And this has been associated with the neurofibrinosis 1 and other craniofacial abnormalities. Types can be peripapillary, eccentric, and universalis. So there are three types descriptions of the myelinated nerve fibers. If it's associated with the disc, it is called peripapillary, and if it is separate, it's called isolated. And if it is filling the whole fundus, it's called universalis. So these are some of the classifications of the various types of MNF or myelinated nerve fibers. So you can get other complications which can rarely happen apart from optic atrophy and field defects. Yes, you can get ischemic retinopathy, where you can get CNP areas and capillary aneurysms at the area of large MNF. And sometimes because of this ischemia, retina becomes thin, and secondary tears with retinal detachment can also happen, but these are all extremely rare complications, which is not usually seen in our clinic. So next is the optic nerve head drusen, which is nothing but the calcification of the axonal calcified axonal debris, which accumulates at the level of the optic nerve, and usually it's buried within the optic disc. But as the age advances, when the overlying tissue sort of atrophies and thins out, it becomes more and more prominent. So presence of ONH drusen in family members shows there's increases for the children to get, and usually it's asymptomatic until it can produce secondary complications, and that can include secondary optic atrophy, secondary peripapillary choroidal neovascular membranes or subretinal neovascular membranes, and these are some of the complications which can happen with the ONH drusen. So just showing when you have a elevated margin of the disc, this is one of a young patients who was referred as papilledema to a clinic. You can see the presence of sort of edematous optic disc with blurred margins and raised margins. And the simplest test to confirm the presence of ONH drusen is doing a fundus autofluorescence. It will pick up, shows a shiny white material at the level of the optic disc. But if the overlying tissue is still not atrophied, it may be difficult to see in autofluorescence. So there you can do a OCT also shows that the presence of this material in the inner layers, unlike optic disc edema, where there is thickening of the nerve fiber layer, which is not usually seen in optic nerve disc. But the easiest test is the B scan or ultrasound, which can mimic foreign body like reflex or hyperreflective echo at the level of the optic disc. So this is one of the simplest tests which can do both autofluorescence as well as B scan. You can easily pick out optic nerve drusen. So if you're in papilledema, what you will see is a crescent sign or the presence of fluid around the optic nerve in the sheath. So this will pick up whether it's a papilledema or optic nerve drusen. So optic nerve drusen, you get hyperechoic echoic lesion at the optic nerve. In papilledema, you get a hypo around the optic nerve, which is the presence of fluid in the arachnoid space, and then the papillitis or ONH optic neuritis will get a thickened optic nerve with a so we are whether the optic nerve is enlarged in size, that's a crescent hypoechogenic lesion, or whether there's a hyperechoic gene. So this will be with these findings you can differentiate between optic nerve drusen, papilledema, as well as optic neuritis. So complications can include, as I told you, CNM, which is seen in the right side picture, peripapillary CNM. One of the DDs for peripapillary CNM in a young patient. In adult patients, you always above 50 years, you talk about wet AMD. But in young patients, one of the DDs, apart from myopia, posterior segment inflammation or posterior uveitis, post-trauma. So all this can be cause of young CNMs. But apart from that, one of the other DDs you have to keep in mind for young CNM is optic nerve drusen. So on the left side, what you see is an unusual case of vein occlusion secondary to optic nerve drusen, which is not very commonly seen. It's a little bit unusual find. So last, which you are seeing is the Aicardi syndrome, where you get sort of a lacunae, multiple areas of lacunae, the larger disc, areas of absence of chorioretinal thinning, which is called as a lacunae, associated with the other cerebral anomalies. So what you see here is microphthalmia, retrobulbar cyst, macular scar, sometimes can lead to regardity, pseudoglioma, cataract. So all these things can happen. So what you see is a whitish areas which are otherwise called as lacunae. It's a rare in syndrome. It's called Aicardi syndrome. So we have to. This is one of the DDs for large optic disc. I think I will stop here and take questions. Thanks so much. Thank you, Santosh sir, and thanks, Ritesh, for the nice introduction. So there are questions somebody can, so I'll stop sharing and probably I can put up the questions so we can go ahead from here.
Thank you, Dr. Saravanan, sir. That was quite an interesting presentation and a very comprehensive one covering all aspects of optic disc related anomalies. Rolika, can we move ahead to the questions? There are a couple in the chat box.
Yes, sir.
Okay, the first one is from Dr. Sohini. She wants to know why is there a risk of glaucoma in tilted discs, sir? That's what I think she means.
So again, the disc is, because it's an oblique entry, disc is sort of, the lamina cribrosa is a little bit more thinner. They are more prone for damage. And associated findings, the exact, I don't know why the open angle glaucoma is more common in these patients, but when the pressures increase, the disc is a little bit more thinner, and the lamina cribrosa, because of the oblique insertion, they are not very strong. And the risk of vision, glaucomatous optic nerve head damage progression is a little bit more higher than compared to the routine POAG patients.
Can I just add another point here, Dr.
Yes, sir, please go.
So apart from this, Dr. Soni, there is an interesting corollary to it also. There is an entity called as tilted disc syndrome, which is actually not a glaucoma, wherein the field changes are seen without any glaucoma changes. What Dr. Saravanan talked about, why IOP glaucoma risk is high in a tilted disc, while tilted disc itself can also present as field defects opposite to the field of where the disc is tilted, which may not be glaucomatous at all. So those are to be looked for progression, and you can just have a tilted disc syndrome.
So the tilted disc syndrome can itself present with field defects in the absence of glaucoma, as Ritesh pointed out, that I put it in the slide also. So field defects can be associated factors in tilted disc syndrome, even in the absence of glaucomatous damage.
She also wants to know, Dr. Saravanan, how does the scleral tissue graft get stuck into the pit?
That was a very interesting video. So
yeah. So it's not like, I mean that people have sometimes tried a little bit of visco or sometimes blood to make it stick, but it actually doesn't need to stick. You just sort of push it inside and it doesn't move. So because of the intraoperative inflammation, the small fibrin-like metal deposits on the retina during surgery, and usually this itself is enough to make it stick. And to give time for this addition to happen, we inject some sort of tamponade, usually gas, and sometimes in very young children we inject oil also if they cannot position, so that this sort of pushes the graft into the close association with the pit, and that slowly sticks on its own. Usually it does not move once a few hours afterwards. It doesn't move actually. You don't need any sort of sealant or any special element, special material to make it stick.
Dr. Saravanan, what has been your experience with using a tissel glue, fibrin glue, basically?
So I am not used because these are all extraneous material which can produce secondary inflammation. So best to use the material which are present in the eye itself rather than something else. So I feel using sealant inside the eye can produce some sort of secondary inflammation. I am not personally used, but we are quite happy with the scleral graft, which is very easy to sort of design from the patient's own sclera.
Sony wants to know, what laser are you using? Is it the yellow laser or the treatment of optic?
So no, usually the routine laser, which is the double frequency YAG, that's what we routinely use. People have recently, if you have yellow laser, you can use, but no, what you use for routine for focal and PRP, the same laser can be used for this, and you don't need any special laser actually. So, but the success rate with this laser alone is not that very great, and as can have some collateral damage also because you're treating the papillomacular bundle area. But because at that time we did not have any successful treatment, that was the commonly tried treatment modality quite a few years back.
And if I'm not wrong, herein the purpose of the laser when we were doing it more often was to create a kind of an adhesion between the RB. Yeah. So we needed a proper argon laser which could cause enough scarring in the peripack.
Exactly. You cannot use the red laser. I mean, other so you have to induce inflammation and secondary scarring. And this works only when the fluid at the level of the papillary bundle area is less. If you have considerable fluid, the laser will not take. So that is one of the causes of failure actually. There's a gross separation between the RP and the neurosensor retina at the level of the laser. So laser will never take. So only when there's shallow fluid only it will be effective. So that's one of the reasons why laser used to fail quite often.
She also wants to know, can you tell us about pseudoglioma?
Pseudoglioma is what you call mimicking retinoblastoma. That's a totally different entity. Probably so white reflex. That will be like a DD for white reflex. So which can include retinopathy of prematurity, congenital cataract. So pseudoglioma only told, no?
Yeah.
Yes, sir.
Pseudoglioma doesn't come in what we discussed right now. It is DDs for retinoblastoma. So probably you will have to talk about other white reflexes which are not retinoblastoma. Anything else? So it's, I mean, probably not related to this topic. Coats disease, secondary, cataract, secondary RD, secondary to retinopathy of prematurity. So these comprise the entity called pseudoglioma. Pseudoglioma per se means white reflex, which is not retinoblastoma. That's what the question was, right? No, Ritesh?
Yes.
Yeah, absolutely right. Absolutely right.
But this doesn't come under the today's topic. Probably, if somebody talks about white reflex and retinoblastoma, you can ask this question. Probably doesn't come under today's area of interest. That's what I thought.
Yeah, that's right. Rolika, any more questions on YouTube?
Yes, sir. So there are a few questions on morning glory syndrome. So I'll go one by one. So the first question is that how often do you see combination of morning glory syndrome with other syndromes, like along with Aicardi syndrome or presence of Bergmeister papilla or the presence of a coloboma?
No, these are all separate entities. It's not like associated. It's not called associated. It's sort of allied entities you can call. So when you have a large optic disc, when you have to think about presentations. So a large disc can be because of morning glory disc, which is a separate entity. And then you talked about Bergmeister's papillae. Bergmeister's papillae is just a gliotic tissue at the position at the level of the optic disc. Just got no symptoms, no vision loss, nothing. It can be seen sometimes mistaken for other diseases. That is Bergmeister's papillae, remnant of the what do you call that? During the process of development of the primary vitreous when the hyaloidal artery, when it regresses, it can produce this residual tissue which is called as Bergmeister's papillae. And third was, what did you ask? I forgot. Morning glory syndrome.
So I think the question was coloboma associated with
optic vascular. These are separate entities. They're not allied disorders. They are separate entities, and they don't occur in unison. They don't occur in a single eye. These are all separate entities. Optic nerve coloboma, Bergmeister's papillae I didn't mention because it's a routine common finding. It's a normal sized optic disc where you can get a small gliotic, which is a remnant of the hyaloidal system during the development of the primary vitreous. That is separated.
Okay, sir. So another question on morning glory was that in a morning glory syndrome patient, what would you do? Would you do a fluorescent angiography, or you would prefer to do just OCT?
So in a primary morning glory syndrome, usually we go by fundus exam because most of these kids not easy for doing fluorescein or OCT. So when you are seeing abnormal findings apart from the optic nerve disc anomaly, so usually first what we do is ultrasound to see if there is any RD present, especially the patient is uncooperative and you're not able to see the fundus clearly. We do ultrasound. So the patient is cooperative enough, we can do OCT. FFA is usually not needed because the fluid is usually regmatogenous, and if RD is present, we'll have to go for surgery, vitrectomy with silicone oil with the encerclage.
Right, sir. And sir, in these patients, what is the visual prognosis and how often do you keep the follow-up?
Morning glory syndrome, most of the eyes have quite poor vision. Only less than 30% have good vision. So most of the patients have poor vision. And if there is associated refractive errors, we'll have to focus on amblyopy therapy also. Follow-up will be every 6 months in kids. And probably now in the adults, you can every once in a year you can call, provided there is no new vision loss.
Right, sir. So another question is that in cases of optic nerve drusen, so when does an optic nerve drusen become cause a retinal detachment?
Optic nerve head drusen does not cause retinal detachment. Other complications secondary to optic nerve drusen is one is because of the pressure effect. You can sometimes get the secondary optic atrophy, and sometimes it can cause. Rarely, it can cause. I showed you one of the slides. I showed you presence of central retinal vein occlusion secondary to optic nerve drusen. But more commonly, what you see is the peripapillary CNVM. So when you have a young patient with a CNVM or a subretinal neovascular membrane or a choroidal neovascular membrane, so you have to think about optic nerve drusen as one of the causes. So other causes, commonly what you see is CNVM means old patients wet AMD. But in a young patient, when you see a wet AMD like picture, so one of the DDs is ONH drusen, second is high myopia, third is secondary CNVM, secondary to posterior uveitis, healed posterior uveitis, like what you call Jensen choroiditis, TB, all those things, and then choroidal rupture secondary to ocular trauma. So these are, and then angioid streaks. So these are some of the DDs which you have to tell. When suppose you have a macular scar mimicking a CNVM in a young patient, if the examiner asks you what are the possible causes of CNVM in this particular patient, so you have to talk about all these, like post-traumatic choroidal rupture, ONH drusen, secondary sequelae of resolved posterior uveitis, and then angioid streaks. These are some of the DDs for a young CNVM.
Okay, so there is a question from Sony right now that could you please tell us about the congenital optic disc pigmentation?
So yeah, this is actually a script actually because of lack of time. It's not a very commonly seen thing. So congenital optic nerve this pigmentation can happen. Sometimes we call it as ONH melanocytoma. If it's a little bit more prominent, we call it as optic nerve ONH melanocytoma also. So this is nothing, but it's not a significant. Usually the vision is quite good in these patients. So not a big serious disease. This is.
Okay, so how often do you see a presentation of an optic nerve glioma in one eye and optic nerve meningioma in the other?
Okay. Okay. I usually in retina we don't deal with this. Probably this is a question you should ask a neuro-ophthalmology specialist. How frequently is the question? So I don't think I am the right person to answer this question.
Right, sir. So actually, this is quite an important question for the postgraduates. The presentation today is quite important because you will have long questions coming on this, and it would be nice if you could put the congenital, like the developmental part, along with your answer in this. So would you agree with that?
Yeah. Okay.
Right, sir. So another question is about I think this you have already covered some, but okay. Another question is that could you explain the optic nerve findings in neurofibromatosis?
So what are the possible? Okay. So neurofibromatosis. Let me come back. Can you? If there are any questions, other questions, you just carry on with other questions. We can talk about this a little bit.
Sure, sir. Ritesh, sir, would you like to put in some pointers for the postgraduates regarding the topic today?
So as far as I remember from their exam point of view, as you rightly pointed out, embryology and development of optic nerve and optic disc and the optic cup is a very important topic. If that comes as your question, somewhere in long question, adding these disc anomalies would give you those extra marks. So you need to, if not anything, first learn to enumerate them all and understand why each of them is happening, which are because of closure of the optic fissure. If it is happening, what are those defects? So you need to know these well. Instead of going, I would say, into real intricacies of how each of them is managed, it would be better if you first try and just focus on what each actually means, and it's different from other, and where all you get associations of in which syndromic conditions.
Yes,
With
sir.
regards benign conditions, I would say optic nerve head drusen is very often differential, which is missed out, especially when you get a case of disc edema. So you have a patient with bilateral disc edema, and as a spotter, as an MCQ, I have seen it come in FRCS papers. I have seen it come in ICU papers. Optic nerve head drusen, ultrasound photograph, mimicking optic nerve head edema, disc edema is very, very commonly discussed and very commonly asked. So don't miss. It's a very small topic or paragraph in your CANSKI, but a very important one entity. You can't skip on it. So just
Right,
remember
sir.
this.
So actually that reminds, sorry, continue,
Yeah,
sir,
please,
please.
please ask.
So actually that reminds me that when I was trying to trace back the embryology component of different topics, I can recall that when I was writing about the like making my notes regarding optic nerve anomalies, I could trace that there you can actually make a column wherein you have embryology part on one side, then along with the disease that is caused if there is an anomaly at that particular time of embryological development. It correlates with the syndromes that can present, and then a management. So even if in 2 pages you have all of this together, that's all that your answer needs. The teacher knows that you've got it right. The professor knows that you have it sorted in the mind. So it's good that if they can draw that diagram along with the anomalies in the same particular table, I think that would be good.
Another thing I suddenly remembered when we were preparing, there used to be one paper from Survey Ophthalmology which described retinal detachments in with the retinochoroidal colobomas and optic nerve head colobomas. It was a
Okay.
very beautifully written review article in Survey, which described how different detachments can happen with colobomas and optic nerve head colobomas. Detachments only involving the normal part, detachment involving only the coloboma part, and a detachment involving both of them. How are they different? Where possible breaks can happen? Explained very beautifully in that review article. I'll see if I can find it and post it for you, Rolika. You can share it. Otherwise, it
Great.
was
Yes.
a survey paper. Yeah, it was a very beautiful paper. I remember suddenly.
Usually, with the only the optic nerve head coloboma, you get sort of a serous detachment, which what you normally you would see in a optic nerve pit also, which has a sort of a waxing and manning course. So I have tried sterile graft in one of the serous detachments associated in a one-night patient in the optic nerve coloboma. Same technique I have tried. But when you have a retinochoroidal coloboma, the most common cause is a rigmoid retinal detachment, where the break is within the thin tissue within the colobomatous zones. Even though rarely you can get a peripheral break like a routine Regardie, but in retinochoroidal coloboma, when there is fluid, so usually you should think about Regardie. But when there's only a ONH coloboma, it is morely a serous RTV, like in what you would see in an optic nerve. So the neurofibromatosis, what in the retina, apart from myelin retinal 5, what you see is a astrocytoma. In one of that's what you see in posterior segment. But there are other various findings which can happen, intraocular findings which can happen. Probably neurofibromatosis will come as a long question for you during the exam, right? From various things like lesion nodules, lead abnormalities, apart from optic nerve tumors like gliomas. So I think that's it itself is a long question for you, probably neurofibromatosis.
Yes, sir. It does come as a long question, and it would be nice if you have, I mean, if you all have your answers framed in advance. I say it repeatedly, but the postgraduates, you should make sure that you have your answers sorted with you. It helps in 2 ways. One is that you're already prepared for your answers, like you're prepared for the exam, and automatically it gets compartmentalized, and you have it always in your head. Even later in fellowship or when you're as a consultant working, you'll always remember them if you categorize them well. Is that right, sir?
Yeah, correct. So retina only we usually what you see is an myelin retinal fiber and retinal astrocytoma, which are quite rare manifestations. But eye itself, we have so many various manifestations. So you can probably prepare it and make a sort of mnemonic for you to remember in case this question comes up.
Right, sir. Nitish, sir, would you like to put in some input?
I think quite rightly summarized. It's quite an interesting discussion, and I hope postgraduates have had a great learning today from this topic. This topic has a lot of long question, short question materials. So yes, revise this very thoroughly. it has a lot of MCQ value from FRCS, FICO papers. So photographs of all these anomalies I have seen somewhere or the other in some form of MCQs.
Yes, sir. I agree.
It's a very important topic. And somehow all these international papers.
And they're repeatedly asked in ICO exams too.
Neurofibroma and optic disc anomalies are their favorite topics, and so please go through them very nicely.
That's true, sir.
Thank you, Saravanan sir, for really covering them.
Thank you, sir, for covering it so beautifully, and thank you for taking out your time. I know that you're busy right now, and still you made sure that you streamlined it very well and you presented it so beautifully. Thank you so much, sir, for your time.
Thanks.
Thank you. We'll see you all on March 30th next. That would be Drug Toxicity of the Posterior Segment by Dr. Mudit Tyagi, sir. So see you all next on 30th of March.
Have a good night.
Thank you, everyone. Good night, sir.
Thank
Thank
you.
you, Nirtesh, sir. Good night.
Good night.